Hello, everyone, and welcome to this webinar entitled Role of Liver Health in Metabolic Health in the Management of Obesity and Diabetes, New Developments in the Management of MASLD. This activity is supported by an independent medical education grant from Boehringer Ingelheim Pharmaceuticals Incorporated and put on by the American Heart Association. This is our agenda today. I will run through our conflict of interest, some housekeeping items. We'll do a quick poll. I'll review the state of the field, and then we'll spend the majority of the time from our guest speaker, Ken Kuzi, and then we'll finish with some questions and answers again. I ask you to please open the Q&A feature at the bottom of your screen. And if you have questions, you can drop your questions throughout the presentations. We'll do our best to answer them at the end. So I'm Rich Aukus. I'm a professor of internal medicine and pharmacology at the University of Michigan. I have the pleasure of hosting this event with my good friend and colleague, Dr. Kenneth Kuzi, who's a professor of medicine at the University of Florida. So these are our conflicts of interest. And I will note that the discussion of off-label treatments will be included in this webinar. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the American Heart Association. The American Heart Association does not endorse any products or devices. The learning objectives for today are, number one, to describe the pathways and risk factors that lead to obesity and metabolic benefits extending beyond weight loss, such as metabolic dysfunction-associated steatotic liver disease, or MASLD, and some people call it MASLD, metabolic dysfunction-associated steatohepatitis, or MASH, cardiovascular risk, type 2 diabetes, and chronic kidney disease. Number two, to discuss the important role of the liver in metabolic health for people living with obesity, including but not limited to screening for and diagnosing of metabolic conditions. And number three, to identify the potential role of glucagon and its receptors in the management of obesity and MASLD or MASH. So we're going to start with a little audience poll here. So the first question, how would you rate your current understanding of the mechanistic pathways involved in obesity and their broader metabolic effects? This is just a question of your level of understanding. Number two, how would you rate your current understanding of the liver's role in metabolic health and its relevance for screening and diagnosis of metabolic conditions? And number three, how would you rate your current understanding of the mechanisms of glucagon and its receptors related to obesity and MASLD and MASH management?
Thank you so much for teeing up that poll, Dr. Akis. I see a lot of responses coming in, but I definitely want to give folks time to answer the 3 poll questions and participate. I'll give it maybe 10 more seconds, and then would you like me to show the results?
Sure.
Okay, here you go. Here come the results.
So we have a spread through the middle. Okay, very good. Well, that's the reason you were all here today. So, okay, I'm going to just sort of give you a few slides to kind of lay what I think the state of the field is. No, I don't work particularly, this is not my area of interest, but I am aware of it. And so, like, has everybody heard of MASLD? And so, the prevalence of MASLD is about 30% of adults. So it's not a rare disease. It's 1 in 3 people. And it's the majority, 70 to 80% of adults with obesity and 60 to 70% of adults with type 2 diabetes. So if you ask the random city-dwelling adults, and this was one poll of 4,000 people, 19% of them have heard of MASLD, but 78% had heard of fatty liver. If you ask 200 primary care providers, a little over half of them have heard of MASLD, but 87% have heard of fatty liver. And in part, that's because MASLD is a new terminology that's only been in existence for a few years. Now, the complications of MASLD are clear. The prevalence of advanced fibrosis amongst U.S. adults with type 2 diabetes is about 20%. And this is also a risk factor for cardiovascular disease and cancer. So MASLD-associated cirrhosis develops in about 0.6 to 2.3% of patients per year, and they can develop hepatocellular cancer. One of the most common indications for liver transplantation in the United States is MASLD. And MASH is the #1 cause of liver transplantation in women, as well as the cause of hepatocellular carcinoma. There are poor health-related quality of life scores in patients with this condition. There's a large health-related economic burden in patients with MASLD. Now, how do we treat this? Well, weight loss and metabolic improvement, sure, but that's difficult to do. It's been historically very difficult to do. There have been studies of pioglitazone, which actually Dr. Kuzi was the leader of that, tirzepatide, survodutide, and others that are currently off-label. We'll mention those. There's resmetirom, which is approved for use when the MASLD is associated with moderate to advanced fibrosis. And this is a thyroid hormone beta agonist that is selectively activated or unmasked in the liver cells. So it's sort of targeted therapy of thyroid hormone to the liver. And then recently, semaglutide has been approved for use. It's a GLP-1 receptor agonist in patients with MASLD and moderate to advanced fibrosis as well. So the quandary that I have, and that I hope gets clarified today, is should all adults be screened for MASLD, or at least given the screening that we do for type 2 diabetes and obesity, how should we incorporate screening for MASLD? When and how should we diagnose it? Should we use the FIB-1 index? Should we use FibroScan or ELF? Should MASLD be treated independently? We know that most of the treatments that we use currently for MASLD will also improve obesity and hyperglycemia. So should we just be treating the hyperglycemia and obesity and let the MASLD get better as a secondary consequence? Or do we need to think about treating the MASLD independent of metabolic improvement? So with that as a backdrop, I want to turn it over to Dr. Kuzi, who has spent most of his career studying this problem and is going to educate us on some of these aspects today.
Well, thank you, Rick, for that kind and thorough introduction. For me, it's a pleasure to be here with you, and delighted to try to share what's in the field, and hopefully, more than anything, with the goal that you'll be able to be better prepared in taking care of people this afternoon in the clinic. So with that, I'm going to move forward. I think I still don't have control here. Oh, there we go. Okay, so this is from National Geographic. I was delighted when this came out because it was, I think, one of the first observations or studies that have included the liver as part of the targets affected by obesity. And you can see if here, if you look in the lower corner, this is somebody who is lean. You see clearly a significant contrast. And this fat infiltration in the liver is going to have both metabolic consequences, and it's going to be affecting pretty much the liver and putting it at risk of cirrhosis. So this is extremely important and something that we will try to prevent with this work. So I'm going to move on to the next slide. So the way that I like to conceptualize this is that we're pretty good now in cardiorenal disease prevention and again, it always incorporates lifestyle, but the pharmacological agents that we have to manage obesity and type 2 diabetes improve both aspects. My goal is for you to include NASH in this equation, okay? And this is something that we only have 30 minutes, so I'm not going to be able to cover every slide, but I'll just include some to give you some awareness about where we are. So this is one of the latest worldwide, global burden of overweight and obesity across the world. And again, we lost a little reference here somewhere, but again, darker red means more obesity. And in the United States, this orangey red means that about 70 to 80% of adults are overweight or obese. In the Middle East, this is even higher and getting worse. Now, this is where we are going to be in the next, by 2050. Now, I have to say, every time I'm old enough to have seen these for the past decades, they always underestimate where we're going to be. But you can see North Africa, Middle East, you're going to have more than 60% of the people with obesity. Latin America also pretty dire numbers. And here we are in high income countries and of Europe and Central, also in parallel heading that way. So a big problem that we're going to have to face in some way. And the real problem is really, it's really a fat attack on other organs. So as you go through this, you can see that the problem with dysfunctional fat is that it's not holding that excess energy in the adipocyte, but that it pours this in the portal circulation in the case of visceral fat, but overwhelmingly everywhere after your BMI is in the obesity range, leading to a production of cytokines, a reduction in adiponectin as adipose tissue becomes dysfunctional, which is key for function of key metabolic regulators like AMP kinase in the liver and muscle. And again, it's also going to cause increased heart failure, impaired beta cell function, and put you into diabetes if you're genetically predisposed, and affecting mitochondrial function globally. So these are just some global slides to show that it's not only lipotoxicity, and again, it's not fat, it's not triglycerides. We figured out that really triglycerides is a way cells store energy, but it's really where it goes from there, either increasing flux of fatty acids to the mitochondria, causing dysfunction, triggering oxidative stress, and some other molecules like ceramides or deacylglycerols. And this is a common pathway for most tissues affected. On the other end, you have glucotoxicity. This audience will be very familiar with that, and beta cell dysfunction. And here are these adipocytes. You can see that they're highly interconnected, talking to each other. And this is, again, not a problem of more fat, but a problem of sick fat. Now, you can also have sick fat being overweight, and there are some lean people who have bad genes and they're from their parents, and also may have dysfunctional fat. But it's clearly more prevalent in obesity. And the last boring slide of mechanisms, but this is so important because what's happening in adipose tissue will modify everything. So that is why, from an operational perspective, us as clinicians can do two things, particularly when it comes to the liver. Either we reduce the mass of fat, which is what we'll do with weight loss, bariatric surgery, GLP-1 therapy, or we change the biology of fat. That's what you do with pioglitazone, which turns that sick fat into, again, a fat of a lean individual that is holding in place the adipose tissue. So, well, this is a very simplistic slide in a review that we wrote. Again, there are genetic factors. Your fat will suffer hypertrophy. This causes a relative hypoxia, triggers ER stress, a number of molecular pathways linked to inflammation. And this will trigger these adipokines to begin recruiting macrophages, because these adipocytes die. There is metabolic inflammation and apoptosis. These cytokines itself reinforce this cycle of making these adipocyte cells more insulin resistant. And in the end, as I mentioned before, there's a flood of adipokines going beyond the adipose tissue to muscle, liver, and other tissues. There's a flux of fatty acids across the board 24/7, and you lose adiponectin, which is, let's say, a hormone that keeps your vascular bed healthy and prevents storage of excess fat in ectopic tissues. So when we talk about this, all these different organs, liver, muscle, pancreas, heart, vascular bed, are all going to be affected by this fat. And I'm giving you this background because with this, you'll understand how heart failure, fatty liver disease, kidney dysfunction are all interrelated. So with that, let's just step forward 2-3 slides into cardiovascular disease in the context of MASH. Again, this is a statement by the American Heart Association. We wrote a review with one of our faculty about it some time ago, but they're all saying the same thing. I mean, indeed, most of the people that have MASH are not going to die of liver disease, but of cardiovascular disease, same as happens with chronic kidney disease and diabetes. So very, very important. And I wanted to point to this recent review that really put together these mechanisms in 3 big buckets. One is MASLD as a promoter of chronic inflammation and endothelial dysfunction, mechanisms that this audience will know very well. The other is insulin resistance, again with endothelial dysfunction and increase of DAGs and ceramides. And finally, another big motivator of lipid metabolism abnormalities, because increases in fatty acid oxidation and this inflammation and this accumulation of fat in the liver, one thing we believe happens is in the setting of insulin resistance, you over-secrete triglycerides to unload the hepatocyte if you want. This will cause, this yin-yang of low HDL and more atherogenic lipid particles. So this audience will know this very well, so we can, I think, surely move on. Now, with this context, at a molecular level, this is another beautiful review. And again, it just points out to what I was saying before. If you compare the healthy heart with the failing heart, it's all focused on mitochondrial loss of metabolic flexibility, inability to really provide the energy it needs, altered key mediators like PPARs and fatty acid oxidation enzymes, NMDA and apoptosis. So it's exactly the same picture that happens in the hepatocyte, the same thing you're going to see at the level of the kidney, at the level of the beta cells. It's just really a fat attack on your energy producing mitochondria. And again, there's ER stress, there's a lot of other things, gut microbiome and whatever. But at a very basic level, this is what happens. And I'm telling you this because there are things we can do. We need to reverse this state of lipotoxicity, and we can do it with the tool that we have, as I'm going to tell you in a little bit. So with that, let's now shift to the kidney. Again, same story. You have hyperfiltration induced by factors associated with hyperinsulinemia. We have a pro-inflammatory state. We talked about adipose tissue. This is all going to put a lot of pressure on those glomeruli, okay? And with this, you're going to basically find yourself in the same situation than in the heart. You're going to have a number of problems happening, not only from a perspective of the hemodynamics, which has been the classic model from the kidney field, but you're going to have, again, this seems like a repetition, but it's a unifying hypothesis as all these same factors are affecting you systemically. The other thing is that less well known is this fat compression can affect the kidney units, glomeruli by themselves. And again, ectopic fat causes inflammation. So it seems very, very reassuring that there's this consistency at each level of the harm of obesity. And if we can translate this into a clear message to our patients, the rationale for using lifestyle changes, GLP-1s, bariatric surgery becomes more and more clear. So with that, let's now completely shift into the liver. But again, we have in the SGLT2 inhibitors, I put this myself as a reminder, SGLT2 inhibitors actually produce a mild state of ketosis and will have a lot of hemodynamic effects that you know pretty well. And again, as you see on the left, I mean, the kidney field has these incredible tools now to do this. Not surprisingly, GLP-1s have shown to be renal protective. And if we keep in mind the background that I showed you before, it comes as no surprise. It was almost evident that this would happen. And again, we have the mitochondria as a very important target. So without dwelling much more on this, I'm going to go straight into MASH. Now, there was still many people are unaware of the change in the nomenclature. I was one of the few endocrinologists in the liver panel. I didn't love this term. And when I tell my patients you have metabolic dysfunction associated steatotic liver disease, the most common question, how many days do I have left, doctor? And then when I tell them fatty liver, oh, it's nothing. So again, both extremes are not that helpful. Fatty liver was removed in a nutshell because it was felt that it was stigmatizing, at least in the English language. In other languages, it's not exactly the same emotional content as fatty. And also with non-alcoholic fat, I mean, it was defining a disease by what it was not. So it's also not exactly the same because it's not only NAFLD was just steatosis, but MASLD is steatosis plus one of the features of the metabolic syndrome. The idea was that liver doctors were to have a positive diagnosis. I have to say that the specificity of this is very poor because 85% of middle-aged adults have one cardiometabolic risk factor, even without steatosis. So, but for whatever it is, I think it does bring to the attention of people with diabetes and obesity that they could have a problem. On the other end, there's alcohol liver disease. Again, when your consumption is more than 50 grams a day in women and 60 in men. It's not that the committee was predominantly had men in the panel, but that men have a higher body surface and distribution of the alcohol, and also the liver enzymes, and the men clear alcohol a little bit more. You should know that one drink is about 14 grams. So you have an idea, a glass of wine, a 12-ounce beer, or or half a glass of vodka is about 14 grams. Now, what was recognized that between very little alcohol consumption, less than 20 grams in men or 30 in women, there was this middle ground, okay, of people that, were somewhere in between. And that's now labeled MASLD, which is MASLD with increased alcohol intake. And still, we do believe, and I think I'm going to mention this at least one more time, alcohol in the setting of MASH, particularly if you have moderate fibrosis, is very harming and synergistic in causing more liver damage. So please keep that in mind and tell your patients. Okay, I'm going to move on to our next slide. And what happens here is if you're going to remember one thing, remember this slide. Particularly, remember this test, FIB4. It's composed of age, liver enzymes, and platelets. And you'll say, well, why age? Well, the older you get, there's more time for the metabolic insult to harm your liver. Liver enzymes, particularly high AST. And again, normal ALT is 30 or below in men and 19 or below in women, not the 40 you get in your commercial lab slip. So if you have an ALT above 30, you probably have a fatty liver. And if you have an AST above 30 towards 40, that's more of a marker of liver fibrosis. And when the AST is higher than the ALT, you probably have somebody with moderate advanced fibrosis if you don't want to calculate the FIB4, or it could be alcohol abuse and increasing more AST. And why platelets? As endocrinologists, we never looked at platelets, to be honest, because if you have portal hypertension, you're going to have, entrapment in the spleen of platelets and they go down. So this is like an index. So if you go to you put FIB4 in any web browser, it will give you the number, okay? Highest risk group, diabetes, followed by prediabetes and obesity. And again, if this number is below 1.3, you have a lower risk. Now, it's not a perfect test, but you have to know that the caveats are, it's going to be low if you're younger than 35, so you can use it. And above age 65, age begins having a disproportionate effect on it. So probably after age 65, use 2 as a cutoff. Now, if it's equal or above 1.3, don't tell the patient you have cirrhosis or you're going to die of liver disease, because it also has 15% false positives. And again, you probably need to do this second test. Oops, sorry. It's really called liver stiffness measurement. And what's measuring is stiffness. So stiffness is being, validated with liver biopsies as a surrogate for a significant fibrosis. So if it's above 8, that should trigger a consultation with the liver specialist. And if the FIB4 is really high, which happens in less than 5% of patients, you should also consider that to be the case. In a nutshell, these are the numbers, particularly in people with diabetes. If you see here, about 70 or 80% have steatosis, about half of them have NASH, and 3 to 5% cirrhosis. So those are the key things that you need to remember. It's something fairly common when we're not seeing it very often. And again, I don't have a lot of time, but you can go from metabolically healthy obesity, which is something we don't understand very well, but happens in about 10% of people, all the way to MASLD with what is an older nomenclature, metabolic syndrome, or with diabetes. And it's something that has a lot of individual variability. Finally, before we get into a little bit deeper into the role of GLP-1s, there are really 3 biologies in MASLD. One is that linked to this part of the equation, steatosis, that affects 70 or 80% of people with diabetes. The factors are, as you said, sick fat, high insulin chronically, like in obesity or insulin. There are lean people who are insulin resistant, and high glucose, which provides carbons for de novo lipogenesis. And now the liver has to say, what do I do with this? And basically it has 2 options. It will either try to burn it, but this high flux at some point causes damage and will trigger steatohepatitis, or I can re-export it as triglycerides. So if you have an obese individual with high triglycerides, low HDL, and an ALT of 35, you don't need an ultrasound. This person has steatosis. So there's not a single day that you don't have somebody with MASLD or MASH in your clinic if you're an endocrinologist or cardiologist. Finally, this inflammation mediated by the macrophages in the liver or Kupffer cells talk to these guys here, the stellate cells. And this is the 3rd biology, fibrosis. So you can have 2 people with the same degree of steatohepatitis. One has bad fibrosis and the other doesn't. And we don't understand exactly why. But if you have diabetes and worsening obesity, the chances are that you're going to head towards fibrosis, okay? So a lot of things we don't understand, but that's where we are today. And 99% of what we know comes from mice, unfortunately, in terms of mechanisms. So treatment strategies are quite obvious. I just brought this so you remember this. Again, from metabolic syndrome, we need to address the different aspects of it. And moving forward, I wanted to bring to you this relatively recent 2025 guidance by the American Association of Clinical Endocrinologists. They did a very good job at defining, with a different name, adiposity-based chronic disease, whether you like it or not. The key thing is really that there is a stage 1 with what we call preclinical obesity with no complications, great to work on your younger adults. Then we have one with clinical obesity. You begin having end organ damage, and then we have related diseases, which MASH is one, right? So that's stage 2 or 3. Know that that's important because obesity is not a one fit all. Again, you have to take a great history. Again, just showing you what's in that review for you to go and take advantage of this resource. And again, if you frame it this way, it's more likely you're going to be successful in explaining where your patient starts and where he's heading, and to follow up with this. So this is more than just a know-how of obesity, okay? And again, the last point is that this is important. I mean, you don't have to get your patient back to be lean for metabolic benefit. So if you take 10%, with 10%, you're going to begin having benefit in almost all complications of diabetes, between 5 or 10% less. But for really reversing inflammation and particularly fibrosis, you need to hit this 10% mark. That's why most times you're going to need a GLP-1 or a bariatric surgery intervention to not only lose it, but keep it off. Okay, so I like this slide because this slide basically puts a lot of information in a very simple way. Where we were before the GLP-1 story was more or less here. We were struggling to get that 10% weight loss. Liraglutide 3 milligrams achieved it in a smaller proportion of patients. Clearly, semaglutide and tirzepatide were big game changers. And then you have here the bariatric surgery interventions on the other end. There are, I'll show you, newer dual triple agonists that are going to push the envelope more into the bariatric surgery range. But this is the information you need to know on what you can offer your patients. Again, I don't want to dwell on this, just to make the point that prior medications worked on the prefrontal cortex, on the hypothalamus. GLP-1s are going to work more on nuclear accumbens, and they, not surprisingly, they're going to hit a receptor close to the opioid receptors, and they really sometimes change the sense of pleasure with food or foods, even the taste of foods. And the other aspect that's truly important is that they're going to work on the POMC and CART neurons, that also bupropion and others work, but they're clearly changing. And when you talk with patients, they really change their interaction and emotions with food, the anxiety of eating, not only satiety. There's, as you know, literature suggesting may reduce alcohol intake. Some people tell me they feel the food too sweet, too salty, and are rapidly reach satiety. I wanted to include this, of course, Dr. Brill, who has worked with me for a long time now at the University of Alabama. Basically, I mean, any way that you lose, you promote weight is going to have a cause a reduction in liver fat. So without having to give you one way of doing it, find out what can be working best for your patient, okay? Very good. This is another important slide that I want you to remember, because it puts in one slide, it has a lot in it, I know what you're thinking, but it really puts in one slide what you need to remember. So you can put in a little, stick it in your office or somewhere. This is all the lifestyle stuff, okay? We know this. Now, for the pharmacotherapy, we have divided in no fibrosis or mild fibrosis into moderate to advanced. Moderate is F2, and advanced is F3. For the liver doctors, they have these specific names for it. This is also called clinically significant fibrosis. And this group of people who have F2 or greater, F4 is cirrhosis, so this is the other group. So the drugs that we have approved, which are resmetirom and GLP-1 receptor agonist, are targeting this population. There are ongoing studies in compensated cirrhosis too. But we want, if you don't have fibrosis, you have MASLD, your pharmacotherapy is basically pretty much the same. GLP-1s or dual agonists. For diabetes, medication, GLP-1s, PIO, and SGLT2 inhibitors that have a lot of metabolic benefits. But the drugs approved for MASH are not for this population because they don't have, they really have to have an effect on fibrosis. As you move down to this target, again, the major difference is that we have liver histology with these agents only. Of course, with semaglutide, I'll show you the phase 3 data. With tirzepatide, it's phase 2, and survodutide. And then pioglitazone, there's 6 smaller studies have all shown reversal of steatohepatitis. And then the 2 drugs that I'm going to show you in a little bit more. We want to prevent getting into cirrhosis, but still the pharmacotherapy for F2, F3, and early cirrhosis is about the same, but you should avoid drugs that are not approved. No drug is approved for cirrhosis. And again, when you have ascites or complications of cirrhosis, you need to stick to insulin because they've not, the other drugs have not been tested and could have some unknown side effects. Another thing that people don't know, and we're getting close to the end, is that the ADA, as you know, for many years now has recommended for cardiovascular disease, the GLP-1s, for heart failure and CKD, SGLT2 inhibitors, and now adding GLP-1s as needed. The other thing that we all know well is the role of GLP-1s for obesity. But what most of you don't know is that there's a new category down here that if you have MASH in the same way you choose a SGLT2 for nephropathy, you should be choosing a GLP-1, a dual agonist, PIO, or the combination of PIO and a GLP-1. There's a lot of dual agonist combination therapy, GLP-1 and PIO, that show a reduction in liver fat, although there's no data on histology yet. So keep this in mind. A word about resmetirom. There are abundant receptors in the liver, and it can reduce steatohepatitis and fibrosis. Placebo subtracted, the effect on steatohepatitis is about 20%. The effect on fibrosis is about 12%. And again, there's an editorial that I wrote about it. First drug, very promising to offer a new therapy. The drawback will be its modest effect against its cost. It's $50,000 a year. Again, GLP-1s are also expensive, about, depending now, prices have been slashed, but it would be more in the, say, $5,000–6,000 a year. So it has to be used cautiously. And again, particularly for F2s, I personally think F3s that have not responded to GLP-1. And I think working in a multidisciplinary team, letting your hepatologist get involved and decide if that's would be a good choice. For pioglitazone, I said there are many studies. We were lucky with all this group to do this initial study in the New England, and then people with prediabetes or diabetes. Then we combined it with vitamin E. The Annals paper was a long-term study. Dr. Sanyal and Clinical Research Network at the NIH did another study showing improvement in steatohepatitis and another one. So basically what it does, it just targets adipose tissue. It targets this part of the equation. There are some direct effects, but by decreasing inflammation, since the PPAR gamma receptors are so abundant, reduces fatty acids. There are also PPAR gamma receptors in the macrophages in the liver and the stellate cells. So basically, it has shown more an effect on inflammation than fibrosis. But again, still awaits a large multi-center study to prove its efficacy. And it also reduces cardiovascular disease by many mechanisms, but I think we can move on. So with this, remember that on the background of a GLP-1, the issue of weight gain is not really an issue. And again, the issue of heart failure is really doesn't cause heart failure, but if you have undiagnosed heart failure and water retention, you're going to maybe get in trouble, but it happens rarely. GLP-1s, I know this is just a slide to switch. You know a lot of the mechanistic effects. Remember, that talking about the liver, I want to remind you all the cardioprotection associated with GLP-1s, and that most of your people with MASH are going to die of cardiovascular disease. So even if you don't reverse fibrosis, but you halt it, you're going to be reducing cardiovascular disease and reducing mortality. So still, that data needs to be shown specifically in a MASH population. But the study with semaglutide continues for 5 years or more, and Lilly has also started a study with tirzepatide and retatrutide. The last 3 or 4 minutes, let me just walk you quickly over the clinical trial so you know what the evidence is. This is with semaglutide. You see here this this is the phase 2 study we did. Again, almost 60% of the people, this is a daily dose of 0.4, equivalent to the 2.4 dose, compared to 17% of placebo had benefit. Fibrosis did not reach statistical significance, but then came this trial published, first announced at the end of 2024, published in 2025, and the FDA in August approved semaglutide 2.4 for MASH based on this benefit in about 60% compared to 34% of placebo, and also an effect on fibrosis. So very nice work. I put this slide to remind myself to tell you that, again, the debate is, what are the mechanisms at play? I mean, is it all weight loss or not? Probably weight loss is the predominant mechanism, but go and see, I'm a co-author, but to be honest, all the merit goes to the first and last authors. There are proteins that are modified independent of weight loss. So I think weight loss is not the end of the story, and this is probably the best effort to show that's the case. Okay, so tirzepatide, you know, a dual agonist of GLP-1 receptors and GIP. Again, the data about 60%, but now even less placebo responders, so a bigger delta numerically, and again, about a 20% effect on fibrosis. Very, very good results. Now it's undergoing a phase 3 study in 4,500 people with a tirzepatide in one arm, retatrutide, a triple agonist in another arm, and a placebo arm. But it's just starting. It'll take a few years to get to the results. Finally, survodutide, another very exciting compound that is more advanced in its approval for, or in its path to approval for obesity or diabetes, but also a very active MASH arm. It's a dual GLP-1 glucagon agonist. Again, these are the standard FDA endpoints: improvement in MASH. You see up to 62% in one of the arms against 14% of placebo. And when you look at fibrosis, again, a delta of about 15%, 12 to 15%. So very exciting results. It's also undergoing a phase 3 trial. And this brings us to the biology, because you say glucagon increases your glucose, but it doesn't increase the glucose at this in this molecule, because it's rather much lower than giving a bolus of glucagon. And I don't want to wear you down with a mouse study, but in this knockout mice study, in the obese mice, there was a big effect on energy expenditure in the liver. Now, mice have a much bigger and active liver than humans, but it does show how the glucagon agonism can work. And the editorial from Dr. Gastaldelli, who's a good friend of mine, pointed out to this increased lipid oxidation in the liver, effects on glucose metabolism that are favorable, improving amino acid metabolism, and also some effect on adipose tissue. So the story in humans is still evolving in our understanding, but at least I wanted you to know where you can go for good sources of additional information. It's something that we're very excited about. More about the future, oral GLP-1s. Recently 25 milligram of semaglutide was approved in the United States with weight loss of about 15%. Orforglipron, also another oral agent, about 15% weight loss. Retatrutide is a GIP, GLP-1, and glucagon receptor agonist with weight losses beyond 20%. Amylin analog, cagrilintide. Cagrilintide is also showing, as you see, benefit and added to SEMA with another 15%. Mazdutide, we talked about survodutide. Pemvidutide is being studied in MASH as well. So a lot of activity, but I want to put a word of caution. It's not just throwing a GLP-1 and I'll see you in 6 months. You need to do work with managing GI side effects, trying to understand, the dietary preferences and protein deficiencies, and sarcopenia has been another big area. So it is complex, and it's not just one size fits all with GLP-1s. You have to work with a team. So in finishing, I hope that I incorporated NASH into your routine, and I want you to leave with these brief, simple messages. Number one, obesity is really the target in which the liver is going to be susceptible depending on genetic backgrounds, coexistence of diabetes, type 2 diabetes. And I have to say that if you have type 1 diabetes and obesity, you're also going to have problems, as you see in type 2 diabetes. The word is to risk stratify your people, all your people with type 2 diabetes, to know if they have at-risk MASH. In other words, you could at risk of cirrhosis MASH, okay? Because we can prevent cirrhosis, but if you don't diagnose it, you can't treat where you don't diagnose, they say. So again, lifestyle, very important. Pharmacotherapy for obesity, GLP-1 for diabetes, PIO or GLP-1. And again, bariatric surgery remains underutilized, highly effective for NASH. With people who are at increased risk, remember cardiovascular disease. Don't stop the statins. Common mistake, liver enzymes slightly elevated, stop the statin. It's not the statin, it's probably MASH. So continue statins. Again, don't continue if you have decompensated cirrhosis, but you can continue even in early stages of cirrhosis. And that's going to be why the most common cause of death is cardiovascular disease. And cardiologists in this audience should be thinking about this every day. There's not a day that you don't see somebody with MASH. So hopefully you'll begin catching them starting this afternoon. And again, you need to work on a multidisciplinary team. You can't do this alone. We learned this in type 2 diabetes and diabetes type 1 a long time ago in the endocrine field. You need to develop your nutritionist, your behavioral modification person, your hepatologist is going to work and create this dialogue. So with that, I think I abused your patience, and hopefully this will be helpful in taking care of your patients starting this afternoon. Richard.
Well, thank you, Dr. Kuzi, for that extremely thorough and informative presentation with some excitement of the new developments, but also some cautionary tales and some clinical pearls that are very useful for managing our patients. We're going to go back to the audience poll, and we're going to ask you those same questions again and see how you score now. So how would you rate your current understanding of mechanistic pathways involved in obesity and their broader metabolic effects? How would you rate your current understanding of the liver's role in metabolic health and its relevance for screening and diagnosis of metabolic conditions? And how would you rate your understanding of the mechanisms of glucagon and its receptors related to obesity and MASLD and MASH management?
Again, thank you, Dr. Kusi, for that wonderful presentation. We have a lot of responses coming in. I do want to give everyone a chance to participate in the post-program poll. So we'll give it about 20, 25 more seconds.
And then after that, we'll go to the Q&A.
I hope I've not confused them more than anything, but it is a confusing terminology and something new for us, although it's been under our radar for a long time.
I would just give it a few more seconds. Okay, here are your results.
Okay, I see a little
Okay.
shift.
We definitely have a shift. And I think pretty much most people have a good understanding. Okay. Ken, I wanted to open the Q&A with asking you, with resmetirom, do people lose weight? Does insulin sensitivity improve? Or is it just about steatosis?
There's no change in glucose or metabolism or insulin resistance or weight. So it's it's neutral for all of those. Now, the drug was first published not in 2024 in the New England, but in 2007, I think, by Chip Ridgway, which you probably know.
Right. Yes.
And it was a lipid lowering medication. So it does lower LDL about 20%, which would be very valuable for this population. So from that perspective, it's a plus, you know. And I forgot to mention it can cause some mild diarrhea for unclear reasons or controversial reasons, but so you should consider that also if you're going to start therapy. And the main reason why you want to work with a hepatologist is that you have to get that window. You don't want to give it to somebody
Yeah.
without fibrosis or
Right.
somebody with cirrhosis until it's approved for that indication. And it is difficult because the liver test that I showed you, the liver stiffness, FIB4, and ELF, which I didn't mention, but the ELF is another test. It should be 9.8 or greater. They sometimes contradict each other, so you have to have some expertise in their management.
I see. Okay. There is a question that I need to turf to the AHA. Will the slides and recording be shared?
I have no problems in sharing the PDF.
Well, but to the AHA
Oh, I
people
don't know
is
what the AHA policy is. Yes, whatever their
all right.
policy.
Yes,
Well, all right.
they will be
Angela,
available.
what is the policy?
Yes, we will have this available as an on-demand video
Okay.
in about a month. So
Okay.
but it will be out there. Thank you.
Stay tuned. All right. Second question: what is the best intervention for preventing loss of lean muscle mass? And presumably that is during weight loss therapy.
Yeah, excellent question. So that is an evolving field, but a few things we do know. Resistance training, exercise always will preserve muscle mass or prevent loss, let's put it that way. And remind you need to work with a nutrition that will give the patient options on protein. They have to eat more protein to try to prevent the loss of muscle mass. So you don't, what happens is people don't feel hungry at all. So they don't get well hydrated. So insist on hydration. And they don't eat. So if they're not going to eat, at least tell them to eat foods that are rich in protein. And there's a broad list. I don't have time now. And then exercise, which will also enhance weight loss and weight maintenance.
Right. That's even important. People who aren't undergoing pharmacotherapy. I think we focus on cardio, but muscle burns more energy than fat does. So resistance training is important
Yeah,
also.
resistance training. Yeah.
Yeah. So that should be sprinkled in with that. We only have 2 questions. Any other questions?
Well, talking about GLP-1s when they come before if anybody makes up their mind, I don't see the question. So you come up if somebody has a question. So people say, for example, well, GLP-1s in the rest of the world are very unaffordable. And although prices are coming down, and again, I don't know, many places would not take the NASH indication yet to prescribe. So you're probably going to still, the best indication is under the umbrella of type 2 diabetes. Next
Right.
is obesity. And you know that also approved some of them for chronic kidney disease and diabetes, semaglutide for sleep apnea, tirzepatide.
Yeah.
But those
Common in this
indications are hit or
population.
miss. But just start with diabetes, which is the easiest one, move your way to obesity. And the other thing is in the world, people cannot use these many times. So pioglitazone has come up with a very inexpensive option. And on the background of a GLP-1 or on the background of an SGLT2 inhibitor, there is no weight gain. There's continues to be weight loss and improved effects on the liver, at least on steatosis and metabolic benefits. So keep that in mind. I also didn't mention vitamin E from that PIVN study that I briefly showed you. It also can reduce inflammation in the liver, the steatohepatitis, not so much fibrosis. Again, the controversy is whether it increases the risk of prostate cancer or even cardiovascular disease. So we will never know, but I think that if you have somebody with more advanced fibrosis, it might be worth the risk. Of course, maybe not if they already have cardiovascular disease, but in somebody relatively healthy with advanced liver disease, you may consider that option, which is in the guidelines of the American Association for Liver Disease.
So two other questions here. One is prudent guidance for people who have MASLD about social drinking. Like, what should you limit your alcohol consumption?
Okay, the official guide, I'm going to tell you, don't believe me. The official guideline by American Association of Study Liver Disease, European guidelines, and any other guideline, ADA, ACE, is that if you have moderate to advanced fibrosis, that F2, that is like having proteinuria for a chronic kidney disease. If you live long enough, you're going to get cirrhosis. So the guidelines all recommend no alcohol. Now, if you only have steatosis, which could be promoted by alcohol intake, and only have mild fibrosis, well, social drinking would be okay. You know that the most recent evidence suggests that any alcohol is bad. But again, social 1, 2, 3 maybe drinks per week are probably not gonna shorten your life too much. But again, use common sense, basically.
Okay, and I think there was also a good question about false negatives with FIB4, that half the patients in the Maestro-NASH study had a FIB4 less than 1.3.
Great question. So in the Maestro-NASH, they only wanted to include people in this window, F2, F3, moderate or to advanced fibrosis. The FIB4 mean was 1.4 plus minus 7. So they must have had some people with a FIB4 of 0.8, 0.9, 0.8, 0.9, or 1. So you're going to say, oh, this test is terrible. Well, I'll tell you the history of this test in 30 seconds. The test was chosen because it's already in your electronic medical record. You have to have one. Everybody has a CBC in the United States, a liver function test, and their EMR. It was inexpensive. We didn't have to get into a controversy of promoting a particular test without long-term data on cirrhosis prevention. And we had to say something that can be used in all over the world where resources are very limited. And yes, it has very low positive predictive value. So it's just trying to reduce doing a imaging test or a proprietary blood test in everybody with diabetes, which is 35 million people, and the 70, 80 million people with overweight or obesity. So it's a bad test. So what I would recommend is there's a lot of debate what to do next, but if you lower the limit, you get even more false positives than the 15, 20%. So use your common sense. If you have somebody with a FIB4 of 1, but they have type 2 diabetes, obesity, and hypertension, probably those 3 factors make your chance of getting MASH pretty high. I would do probably the next step, do a liver stiffness measurement. So it's not a magic number. It just has a very high negative predictive value, but not a perfect test. So it's a great question, but use your common sense. It's not a, iron
black and white. All right, I think we have time for one last question about exit strategy. After weight loss with the GLP-1, then what do you do?
You make it easy. Thank you for the last question in 30 seconds. So there is no very good exit strategy because I think you have to use that. What people are trying is to lower the dose to a point that you can stay on that stable weight. The other is promoting really behavioral changes. And third, exercise. So whether or not GLP-1, the only people who are the long-term losers are people who do exercise on a regular basis.
So not just the GLP-1, but that education and that lifestyle changes so that they can come off it.
Like you might remember the greatest losers, the only ones who kept off the big weight losses were the guys who did exercise every day.
Right. Okay, I think we're out of time. So thank you so much for your attendance. Thank you, Dr. Kuzi, for leading us through this complicated field. For more professional resources, please visit the AHA's webpage that's indicated here. And with that, I hope you all have a great afternoon and rest of the week.
Thank you. Thank you, Rich. Great job.